The topic of today's lecture is Scleroderma Part 1. In this lecture, we're going to study about scleroderma and what it entails. So, we'll start with what scleroderma is. It is a disorder or a group of disorders which lie in a spectrum of diseases which are connective tissue disorders and show signs of autoimmunity, and they primarily affect the skin or the connective tissue in the organs. Now, this affection of the skin can be either localized or it can be diffused in both of these scenarios. Now, a diffuse, thickened, edematous skin in a patchy scene is hallmark of any scleroderma patient. Skin is the one organ that is primarily affected in any case of scleroderma. Either it's the localized one or the diffused, or it is systemic scleroderma. But one thing remains, that it is a group of disorders, that it has a spectrum. On one end lies simple morphia, that is, the patient only shows signs of simple thick skin without any ulceration or any signs of infection. On the other end of the spectrum is the crest syndrome, which is, in simple terms, is highly aggressive form of systemic scleroderma, which can reduce both the mortality and increase the morbidity of this particular syndrome. So scleroderma is not only multi-organ, but it also is highly progressive, that it only starts to move in the mortality, in the morbidity way, that it only increases in morbidity. There is no cure for this disease, as it is both autoimmune and because we can only slow it down, or we can perform palliative care, that we only change the effect of the symptoms or signs of the patient. We only try to mild those symptoms, or try to give the cure for these symptomologies, but there is no cure for the underlying pathology. Now, in scleroderma, the epidemiology is highly important because it is very uncommon disorder, that only about 3 in 10,000 people are affected, and age, gender and ethnicity play a huge role in its affection. Now, what happens is that it is usually found in about 30 to 50 years old patients. It is more common in the female gender, as it is with all autoimmune disorders, and it is usually found in the black population and the population of the Asian descent, with people of Japanese, English and Australian descent showing less ratios of affection. So these populations show less percentages of infliction, but other races have high percentages. So age, gender and ethnicity plays a huge part. Now, as for the scleroderma, the cause is unknown. We do not know what is the inciting event, what actually triggers the cascade of all the changes inside the patient and the symptoms which present on the outside. But we do know that there is always some kind of vascular damage, and that vascular damage can happen via a variety of reasons. It can happen due to some kind of autoimmune disorder, or it can be due to some kind of oxidative stress. Whatever the cause is, the causative agent remains unknown, but the following pathogenesis or the cascade events is very known to us. Now, we do note that there are certain factors that do influence its both outcome and the percentage of the population that will be affected. Now, one of the main ones are the genetic factors. Now, genetics play a huge part in scleroderma, even to the point that it shows mild heritability in certain patients. That if you say there's a case of monozygotic twins, so concordance in those patients is about 5%. That is to say that if one twin shows signs of scleroderma, the chances of scleroderma to present in the other twin is about 5%. Now, this might be a very low figure, but still 5% still amounts to a lot in the factors which contribute to the manifestation of scleroderma. The other factors are mostly the genes which show some kind of effect or influence on the B and T cell signaling pathways, such as the IRAK1 gene or the BLK or CD247. Mostly the genes which are involved in the signaling pathway in T cells and the B cells, these genes are always affected, show some form of activation, and they contribute to the infliction of scleroderma. Now, IRAK1 gene is of particular importance because the IRAK1 gene expresses itself on the X chromosome. So the female population is particularly inflicted by the activation of this gene. So IRAK1 is one of the factors which contributes to the more presentation in the female population, along with the female gender being more prone to the autoimmunity or autoimmune disorders. Now, the other factors which may cause scleroderma are the environmental factors. Environmental factors can be infections, they can be occupational hazards, they can be the diet or the changes in the lifestyle. But among all these, the primary one is always the occupational hazards. Now, occupational hazards are usually termed by the contact of silica with the patient. So, any patient which has some kind of contact with silica are at risk for scleroderma. So, silica miners, people who work at the silica mining facilities, at the factories, or those patients that work at the chemical industry, which work with certain chemicals such as the polyvinyl chloride or the epoxy resins or the silicone plastics. All of these chemicals show increased morbidity and can result in patients presenting with scleroderma. Now, as for the infections, the common culprits are the viruses. Patients usually affected with the Epstein-Barr virus, the cytomegalovirus can present with scleroderma. For diet, patients who either have diet with high intake of tryptophan amino acid or take supplements containing high ratios of tryptophan are particularly affected with scleroderma, because tryptophan is an aromatic amino acid, and aromatic hydrocarbons can cause a patient to develop autoimmunity towards scleroderma, even to the point that females with silicone breast implants are particularly at high risk for scleroderma. So, in short, any contact with silica or silicone can result in the manifestation of scleroderma. Next, we're going to learn about the pathogenesis of scleroderma. Now, the pathogenesis of scleroderma is easy one. We have few steps. The first step, like I said, is always the vascular injury. Now, we do not know that what may cause the vascular injury. The exact event is always unknown, but it will result in vascular cell activation or platelet activation, or the release of reactive oxygen species. Now, whenever this happens, there's always a reaction to it, that there's an increase of infiltration of white blood cells at this site. This results in leukocyte recruitment, especially the CD4 and the CD8 T cells, along with monocytes and B cells. Now, whenever these leukocytes or white blood cells migrate to this area, they will show release or secretion of certain cytokines or chemokines. Now, these chemokines are usually the TGF beta, or the transforming growth factor, or the connective tissue growth factor, and platelet derived growth factor. Now, these particular chemokines are secreted whenever there is this particular vascular injury, and these chemokines and cytokines then release and activate fibroblasts. These fibroblasts then again show signs of activation. This further results in either one of the two events. Either there is an increased proliferation of mesenchymal cells, which then turn into the fibroblasts, or the endothelial cells themselves transition into the fibroblasts. This is what is called an EMT, or an endothelial cell mesenchymal transition. Now, whatever the case is, if the epithelial cells are transitioning, this results in the secretion and accumulation of large amounts of collagen into the extracellular matrix. Now, this accumulation of collagen into the connective tissue and the extracellular matrix is then the hallmark of scleroderma, because it is this collagen that causes the increase in the thickness of the skin and the impairment of the wound healing, which then further results in the ulceration that we usually see in these scleroderma patients. So the other two ways that it can happen, that either due to the vascular injury, there's direct activation of fibroblasts and their differentiation, or due to the vascular injury, there is some presentation of the endothelin 1. Now, endothelin 1 is a presenting protein which causes vasoconstriction, and because of this spasm, there is vasculopathy, which not only causes obliteration of the endothelial lining but also causes anatomical and structural anomalies inside the vessels, which then result in reduced blood flow, causing tissue hypoxia, which then in turn causes fibroblast activation. Now, whatever the cause is, it can be one of these three: either the direct fibroblast activation, or fibroblast activation through the cytokines which are secreted by the white blood cells, or due to the vasculopathy due to the endothelial 1. It will always result in the fibroblast activation and the accumulation of excess collagen inside the extracellular matrix. And it is this accumulation of collagen and increased proliferation of fibroblasts which causes the fibrosis and ultimately the sclerosis, or the permanent hardening of the tissue and organs. And this particular cascade of events, this particular pathogenesis is what causes this particular pattern of fibrosis and ultimate sclerosis. Now, this can happen either in a localized area or systemically. So in short, what we have is always a vascular injury. This results in the endothelial cell activation and platelet activation. Now, this vascular injury will cause activation of fibroblasts. Now, this activation can happen via one of these three pathways. One pathway is the migration, and then the recruitment of the white blood cells, which then secrete these particular cytokines which cause the activation, or they can cause direct activation, or they may present with endothelial 1, which causes the vasculopathy, causing tissue hypoxia, which then in turn causes the fibroblast activation. And whenever the fibroblasts are activated via their proliferation, or when the endothelial cells transition to the fibroblast, they cause increase in the collagen deposition. And this increase in collagen deposition, along with the increase in the fibroblasts, it what causes the tissue fibrosis. Now, this pathogenesis of scleroderma can easily be understood in 3 easy steps. Now, we know that its pathogenesis always starts with some sort of tissue injury. Now, its cause is always unknown, but the factors that may influence are the genetic and the environmental factors, which may be viruses, oxidative stress, or antibodies. Whatever they are, they cause some kind of change in the endothelium of the vessels. Now, whenever that change happens, each endothelial cells are activated. Now, whenever they're activated, they do 2 type of things. One, they start to present adhesion molecules such as ICAM1, or they may start to secrete chemokines such as an endothelin 1. Now, because of these 2 changes, vascular damage starts to appear. And whenever endothelin 1 appears in the cascade of the inflammation, it results in one of 2 events. Either it will cause increase in the cellular immunity or in the humoral autoimmunity. Now, whenever there is increase in the cellular immunity, the T cells start to activate, and then T helper cells start to secrete certain molecules. And these molecules are extremely specific in scleroderma, because it is because of these particular molecules that inflammation pathways moves in the direction of the activation of fibroblasts. Now, these molecules or chemokines are the interleukins, such as interleukin 1, 4, 8. It can be matrix metallopeptidases. It can be connective tissue ligands such as connective tissue ligand 2, or all of these interleukins and cytokines then activate the macrophages. Or if the autoimmunity or the humoral autoimmunity is activated, we get the transition of B cells into the plasma cells, and these plasma cells start to produce autoantibodies. Now, the macrophages then in turn start to produce interferons, the transforming growth factor, the interleukin 13, and the platelet drive factor. Now, whenever these particular subset of chemokines and cytokines are secreted, they cause an activation of fibroblasts. Now, whenever the fibroblasts are activated, 2 things happen. One, the proliferation of the mesenchymal cells, which then turn into the fibroblasts, or the differentiation of these endothelial cells into the fibroblast. Now, whatever the case is, there's an increase in flux of these fibroblasts, which then cause an increase in the production of the collagen and other extracellular matrix proteins at that particular site. Whenever there's more collagen, this causes an expansion in that area. And it is this expansion due to the collagen at this site of injury that causes both the reduced healing, increased inflammation, that is again the hallmark of scleroderma. And this fibrosis then turns into the sclerosis. Sclerosis is the permanent hardening of vessels and organs. And whenever permanent hardening starts to appear, if it's only in the skin, we call it the limited. If it's all over the place in all the systems, the major symptoms are always affected, it is the diffuse scleroderma. So the tissue injury results in vascular damage, which causes inflammation either by cellular way or through the humoral way, that is, the autoimmunities are produced. Now, if the cellular ways are activated, macrophages produce these chemokines, which then in turn activate the fibroblasts. Now, this pattern of events is what causes the pathogenesis to advance in this particular direction. And all of this is hallmark and pathogenic and pathognomic in scleroderma. Next, we can easily understand all of this pathogenesis and pathogenic changes if we start to look at the biopsies of all the systems which are usually affected by scleroderma. The usual culprit is always the skin. Now, if we look at the biopsy of the skin, we can easily see here that there's always an expansion of the subdermal layers due to the accumulation of collagen, and this happens usually at the reticular dermis. Now, reticular dermis shows a huge expansion, and this is the expansion which results in the thickening of this area of skin. Now, if we further look at the reticular dermis, we can easily see that there is the accumulation of collagen at this area, and this collagen then further starts to entrap the adipocytes which are found at the subdermal fat layer. And whenever these adipocytes are entrapped by the collagen, they start to show signs of damage. And as the disease progresses, the adipocyte layers starts to thin and ultimately disappears. So in skin, we find an expansion of the subdermal layers, particularly the reticular dermis, due to the accumulation of collagen. And this accumulation causes the skin to widen and thicken. And this also causes the disappearance of the subdermal fat layer. And whenever the subdermal fat layer disappears, the thickening of the skin increases even more. And due to the accumulation of collagen, skin healing starts to deteriorate because collagen interferes with all the pathways of the wound healing. Another biopsy that we can look at is the lung biopsy. The tissue of the lungs show a patchy infiltration of the fibroblasts. As we can easily see here that fibroblasts has started to accumulate at certain sites in the alveolar space, and this alveolar space, due to the infiltration of the fibroblasts, starts to widen, and this widening is then progresses into the accumulation of collagen into the alveolar interstitium and the alveolar walls, which we can see here. Now, this expansion in the alveolar space and the expansion of the alveolar interstitium along with the thickening of the alveolar wall results in the hardening of alveoli. Now, whenever alveoli are hardened, they are unable to accommodate more air. So the total lung capacity of any lung affected with interstitial lung disease is reduced. Now, along with the infiltration of the alveoli, we also see intimal thickening of all the pulmonary vessels inside the lung. And because of this intimal hardening, the arteries are unable to accommodate or move with the pressure. And this hardening of vessels results in pulmonary artery hypertension. So, whenever the lungs are affected due to systemic scleroderma, we see two changes. One, alveoli are hardened due to the proliferation of the fibroblasts into the interstitium and their wall. So this results in the reduced total capacity of the lungs, and this reduced lung capacity is seen as the symptomology in shortness of breath, exertional dyspnea, sometimes even near syncope, and this also results in the intimal hypertrophy, which results in pulmonary artery hypertension. And these two are again pathogenic and pathognomic of systemic scleroderma. Now, if we look for the changes in the gastrointestinal tract, we see two things. One, atrophy of the muscular layer, that we can easily see here that the musculature in this wall has easily decreased. These are the alveolar spaces, and this is the muscular layer, and the muscular layer has started to disappear, and this disappearance is due to the radical and striking infiltration and accommodation of collagen in these areas. Now this results in the accommodation of the collagen in all over the vasculature and the lumen of the intestinal tract. This results in not only in the dysmotility or even decreased motility of the gastrointestinal tract. So whenever the motility is decreased and the peristalsis is not there, the patient suffer from constipation and sometimes even the diarrhea, and they start to have episodes of constipation and then diarrhea. And if this hardening and changes start to appear in the esophageal area, this results into gastric esophageal reflux disease or GERD. And whenever this happens, this can result in Barrett metaplasia or can even result in the hoarseness of the voice due to the acid affecting the vocal cords. So in GIT, two things are observed: the disappearance of the muscular layer and the overall atrophy of the all of three layers in the gastrointestinal tract. As for the changes in the kidneys, they are extremely observative. We see that the glomeruli are shrunken, are decreased in size, and we see that the arcuate and the interlobular arteries are again showing signs of hardening. And all of this is due to the accumulation of collagen. The collagen around the glomeruli are decreasing their size, and the collagen around the arteries are contributing to their hardening. Next, if we look at the histology of heart, there are two changes. Again, one, both the myocardium and the pericardium of the heart are affected. As for the myocardium, again there is deposition of collagen, and this deposition of collagen interferes with the vasculature and the continuity of the vascular tissue in the myocardium. The other thing that we see are what is called as collagen bands, and these contraction bands undergo necrosis. Now these bands that appear are usually formed of connective tissue and fibroblast along with collagen and other extracellular matrix proteins. And it is these contraction bands which undergo necrosis that can result in one of the two things. One, the myocardium is disrupted. Because the myocardium is disrupted, the inotropic effect of the heart is severely decreased. The heart cannot pump with much force. The other effect that we see is the chronotropic effect. Because these bands and the necrosis can even appear in the conduction pathways, this causes the disruption in the cycle of the cell and the pattern via which all the nodes and the pathways work. Now, this results in the decreased and the dysregulation of the chronotropic effect. That the heart starts to show signs of arrhythmias, dysarrhythmias, and this all results in hypertension, palpitations, and even heart failure, particularly the right side of the heart. Next, we look into the clinical features of systemic scleroderma. Now, systemic scleroderma always has a cutaneous picture, and that cutaneous picture can be classified either as limited cutaneous systemic scleroderma or as diffuse cutaneous systemic scleroderma. The difference between the both of these is the pattern by which the thickening of skin appears on the patient. If the thickening of the skin is only limited to the distal parts, that is the hands and the fingertips, it is known as the limited cutaneous scleroderma. But if the pattern of the thickening of the skin is first the hands, then the forearms, and then it moves from the distal parts towards the proximal parts, that is the trunk. This is known as the diffuse cutaneous systemic scleroderma. First, we will look at the diffuse cutaneous scleroderma. In the diffuse cutaneous scleroderma, the pattern of events and the thickening of the skin along with edematous changes results in two parts of this disease. The first phase is known as the edematous stage. The second stage is known as the fibrotic stage. The first stage, known as the edematous stage, is when the acute inflammation is happening. The fibrotic phase is where the chronic changes have happened to the organs and the tissue and the skin. So during the edematous phase of the diffuse cutaneous systemic scleroderma, we usually see soft tissue swelling along with intense pruritus. These two are the typical signs of scleroderma and are the early manifestations of systemic scleroderma. These are then further accentuated by the appearance of thickening of skin on the face, hand, distal limbs, face, and the pattern is that they move towards the trunk. Then this results in the skin pigmentation, sometimes hyperpigmentation, sometimes hypopigmentation. This again results in the decreased joint mobility because the joints are again mainly comprised of the connective tissue and the cartilage. Now, if the connective tissue is hardened, the range of mobility of any joint is disrupted. This results in the decreased joint mobility. Another thing that can happen is the carpal tunnel syndrome. Now, the carpal tunnel, if it is thickened, results in the infliction of both the median nerve, and this median nerve, when compressed due to thickening of the carpal tunnel, will result in the carpal tunnel syndrome. And last, we also see muscle weakness, some fatigue, along with arthralgia. That the joints not only show signs of decreased range of mobility, but also show painfulness. The next phase of diffuse cutaneous scleroderma is the fibrotic phase. In the fibrotic phase, all the changes have taken place and have resulted in permanent change in all the tissue and the organs. This results in skin indurations, that is the thickening of the skin, will result in decline in sweating. Now this happens because the increase in the collagen tissue causes disruption of all the glands on the skin. The sweat glands, the glands producing the sebum, even the hair follicles. Now because these glands have decreased and they are destroyed, the patient usually presents with decrease in sweating. Now, because the sebum glands are affected, the skin oils are reduced and patients show a very dry skin. Then there's hair loss. Again, all the appendages on the skin lose their function and their structure due to the presence of collagen. Now, skin follicles are also affected, and this results in permanent hair loss. Then there's change in the flexion of the fingers. Now, because the flexion of fingers cannot happen and there's decreased hand mobility, contraction bands start to appear in the hand, and these contraction bands limit the mobility of the hand. Now, these contraction bands can not only appear in the hand but also appear in the joint, and they result in joint stiffness. And joint stiffness is due to the extremely decreased mobility of the joint. Next, we learn about the limited cutaneous systemic sclerosis. In this, the pattern is that the thickening of the skin is only limited to the distal parts, that is the fingertips, the hands, the forearms, the face. The trunk, the shoulders and the back are usually spared. Now, in the limited cutaneous, there is more induration because all of the changes are then accumulated at the distal parts. There is more induration of the skin. There is more multi-organ involvement, which can result in the involvement of the gastrointestinal tract, and that results in the gastroesophageal reflux disease. Then we get cutaneous telangiectasias. Telangiectasias are typical vascular lesions which have a central lesion which extending red small lesions which look like spiders. Like there's a central body of spider and it has its legs spreading out. So telangiectasias are also called spider veins. And this is extremely typical of scleroderma. Usually we see telangiectasias in either scleroderma or in hereditary telangiectasia, and it is always due to autoimmunity. Next, we see soft tissue calcification, that the calcium hydroxyapatite crystal starts to appear and start to deposit in the soft tissue. Now, these are the same calcium crystals which are usually found as calcium stones inside the kidneys. Now, if these calcium deposition starts to appear in the small soft tissue, this results in what is known as calcinosis calcis, that is the deposition of calcium in the soft tissue. Then we have cardiac involvement and pulmonary involvement. Both the cardiac involvement and the pulmonary involvement results in pulmonary artery hypertension, and it is found in about 15% of all patients with systemic scleroderma. Next, if the kidneys are affected, there's decreased size of the glomeruli, which then result in decreased filtration and the GFR. This results in severe pulmonary crisis and pulmonary fibrosis. Now, all of this deposition of collagen may overlap with other disorders such as keratoconjunctivitis syndrome, polyarthritis, vasculitis, and biliary cirrhosis. Next, we're going to talk about organ involvement in scleroderma. The first organ involvement is the involvement of the skin and the vessels, and this results in what is known as the Raynaud's phenomena. Raynaud's phenomena is defined as the episodic spasm of the vessels in the hand. Now this results in first the blanching or the white appearance of the skin, as you can easily see here, and this turns into the blue tinge at the tips of the fingers, which then result in either the blackening of the fingertips or the reduction of the blue tinge, and may result in slow and progressive return to the normal color of the skin. Now, this reaction is either primary or secondary. The primary is a physiological reaction to the cold. In extreme cold, due to the spasm of the vessels at the fingertips, we get this turn of events. First the whitening of the fingers, then the blue, and then the black. But if there is cold, it is primary. But if due to some kind of pathological changes, it is called as secondary Raynaud's phenomena. And it can be due to autoimmunity in scleroderma, in certain infections. But whatever the cause is, Raynaud's phenomena is found in about 90% of all patients suffering for systemic scleroderma. And it is the appearance of Raynaud's phenomena that we diagnose patients with scleroderma, that the time taken from the appearance of the scleroderma to the organ involvement, if it's within weeks or if it is within years. In the diffuse, it is within weeks. In the limited, it is the years. Next, we're going to study about the primary Raynaud's phenomena and its type. Now, the primary one, like I said, is a reaction to the cold. And it is usually classified by either the absence of any other symptoms, such as the thickening of skin, digital necrosis and ulcers, any absence of any family history, or any absence of ulceration or gangrene. Now, if these things are not present, it is termed as a primary Raynaud's phenomena. And if the ANA test is also negative. But if these things of one of these is present, along with the possibility of a systemic disorder, it is termed as a secondary Raynaud's phenomena. Now, it is usually in patients with more than 30 years of age. In patients, it is more severe, it is more frequent, it is prolonged in duration, and it is also more painful. Then, because of this frequency and duration of the Raynaud's phenomena, we get ischemic digital ulcers. And these ischemic digital ulcers can turn into gangrene and necrosis, which then in turn can happen in amputation and loss of digits. Now, this loss of digits can also happen in the primary one if the patient is exposed to extreme cold, and extreme cold will result in permanent damage. But usually the loss of limb is due to the secondary Raynaud's phenomena. Next, we're going to talk about skin features or the skin manifestations in scleroderma. Edematous thick skin is the hallmark of scleroderma. So any edematous skin changes, they appear. Now, they can lead in skin being more firm, coarse, and thickened. Now, this is due to the accumulation of collagen. Now, this results in the extremities and trunk being darkly pigmentation. Now, because this thickening of the skin, its pigmentation can have a reactionary structure, which can appear as hyperpigmentation or increase in the darkening of the skin. But this darkening of the skin can appear as tanning, can appear as spots of hyperpigmentation. But one thing is to remember that it can appear like vitiligo. like hypopigmentation in darkly pigmented patients. So this is what gives what is known as a salt and pepper appearance, that in patients with of Caucasian descent we get hyperpigmentation. In patients with African descent or black patients, we get hypopigmentation or areas with hypopigmentations like vitiligo. And this is what is called in salt and pepper appearance. Next, we get hair loss, because whenever the skin is affected by changes of scleroderma, all of the skin appendages are lost and obliterated. The hair follicles are lost. Because hair follicles are lost, there's permanent hair loss. We also get decreased sweating because all the glands have been lost, particularly the sweat glands and the sebum glands and the eccrine glands. Now, because the sebum is decreased in quantity because of the loss of the sebum glands, the oil on the skin or the skin oil is reduced, and this results in dry skin. Next, because there is accumulation of collagen in not only skin but in the subdermal layers, this can result in the appearance of certain fibrotic bands, and these fibrotic bands further hinder the mobility of the joints. And because the scleroderma, either the limited or the diffuse cutaneous one, both start with the fingertips, this results in decreased hand mobility, that the patient is unable to move the hand in a more range of motions. Then there's muscular atrophy, because the patient is not using his or her hand enough. This then results in the appearance of the contractures in both the fingers, the hand, the wrists, knee, and the elbows. Now, because the collagen is deposited in the skin, and because a thickened skin with collagen is always attached to its subdermal layers, what is known as tethering, this can result in the attachment of the neck skin to the platysma muscle. Now, this results in the appearance of thick ridges on the skin and the inability of the patient to form the extension of the neck, because the skin has now adhered firmly to the platysma muscle. Next, we get what is known as Moscow appearance. Moscow appearance is very typical of a patient with scleroderma, and it is defined as a patient with taut, shiny skin with expressionless face and loss of wrinkles. Now, whenever the patient has a Moscow appearance, this results in thinning of the lips. There is thickening of the face, but the skin around and on the lips is thickened. Now, this can result in the accentuation of certain teeth, such as the incisors. Now, because of this accentuation around the oral cavity, we get what is known as radial furrowing, that there is increased appearance of thickening around the mouth. Now, because of this radial furrowing, the mouth of the patient or the oral aperture is reduced, because all the collagen around the area of the mouth reduces the ability of the oral muscle to perform, and this results in the patient unable to open the mouth to the full extent. Next, the nose is pinched and in a beak-like presentation. Again, it is due to the appearance of collagen and its deposition in the skin. Next, we're going to look at the skin features and how they appear in their clinical manifestation. The first one is the sclerodactyly, and it is defined as the deposition and of collagen at the fingertips along with the thickening of the joints. Now, this can easily be seen in this patient with its thickening of fingertips and contraction bands due to the collagen around the joints, particularly the pharyngeal joints and the metacarpal joints. Next, we have the cutaneous vascular changes. Now, these vascular changes can be seen as either the patient exhibiting cutaneous telangiectasias. Telangiectasias are also called spider veins because they have a central lesion with extending red thin lesions, which give it an appearance like a spider. As you can see in this patient with cutaneous telangiectasia, that there is a central lesion with extending lesions which form like extension, and it is due to the subcutaneous inflammation of capillaries in the skin. Another way cutaneous vascular changes can appear is by vascular changes of the at the fingertips, which appear like atrophic changes and pitting ulcers. These micro angiopathy is seen as these micro pitting ulcers. Next, we're gonna look at a typical feature of systemic scleroderma, that is the acro-osteolysis. Acro-osteolysis is defined by the striking resorption of the fingertips, which can be seen on the x-rays, and it is due to the formation of both the collagen in the skin, which then results in decreased healing and increased inflammation, which can result in osteomyelitis. Whenever osteomyelitis appears, this can further impair both the healing process and the structure of the bones. And whenever both the circulation at that area is compromised, the bone at the tips start to resorb, and this can be seen here in this patient, that both the integrity of the tables and the cortex is extremely compromised, and this is what is called as an acro-osteolysis. Next one is very typical of a patient with systemic scleroderma, that is the calcinosis cutis, and it is one of the parts of the crest syndrome. Now, calcinosis cutis is seen as the deposition of calcium crystals beneath the skin, as you can easily see here. These calcium crystals are composed of calcium hydroxyapatite, the same crystals that form the calcium stones. And the calcinosis cutis not only is pathognomic for scleroderma, its appearance can signal the presentation of the crest syndrome. Next, we have the pulmonary features. Now, the pulmonary features in any patient with systemic scleroderma can be seen as interstitial lung disease or as a pulmonary vascular disease. These two presentations can appear in about 98% of all patients. Other presentations that might appear in a patient with clinical manifestations are the pulmonary aspiration. It can appear as pneumonitis. It can appear like a pulmonary hemorrhage, that bleeding in the alveolar space, or it can appear like obliterative bronchitis, that the bronchioles are again affected. It can also appear as pleural reaction, that inflammation of both the pleura and the pleural space, and can also appear as restrictive ventilatory defect, that the patient's perfusion is compromised. Next is the interstitial lung disease. Like I said, interstitial lung disease and vascular changes appear in about 98% of all patients with clinical pulmonary manifestation. ILD appears in about 90% of all patients with pulmonary manifestations. ILD is defined as increase in the forced vital capacity or decrease in the total lung capacity of a patient. Now, interstitial lung disease is usually due to the increase in the interstitium of the patient due to deposition of the collagen. In the patients with interstitial lung disease, it is usually manifested as exertional dyspnea, as fatigue, as reduced exercise tolerance, and it can even appear in chronic dry cough. The one feature of it is that we also hear Velcro crackles on physical exam. Now, these Velcro crackles are due to the snapping of the fibrotic tissue inside the lungs. Next, interstitial lung disease is usually examined via the physical exams, but can also be diagnosed on imaging. The imaging that is used is high resolution CT scan. And on high resolution CT scan, we can have this typical picture of a patient with interstitial lung disease with a huge fibrotic mass. It can also appear as a mild form of interstitial disease with ground glass appearance. It can appear with ground glass appearance, fibrotic mass with subpleural reticulations. It can also be in a mild form with both the ground glass appearance without any other manifestation. Now, chest X-ray can also be done in a patient with interstitial lung disease, but it is insensitive to the ILD. But it is used to rule out the other causes of these symptoms in these patients. Lastly, we have the pulmonary arterial hypertension, which is due to the pulmonary vascular changes. Now, these pulmonary vascular changes can appear as the pulmonary pressure that is more than 25 millimeters of mercury with a pulmonary capillary wedge pressure that is less than 15 millimeters of mercury. Now, the pulmonary arterial pressure is due to the hardening of the pulmonary artery, and the decrease in the pulmonary wedge pressure is due to the decrease in the left arterial pressure. Next, we have the features of the pulmonary arterial hypertension, and this can present itself as, again, exertional dyspnea, that is shortness of breath on exercise, reduced exercise capacity, the patient is unable to exercise for long duration of times, as angina, that is the pain radiating in the chest due to complication in the vasculature of the heart, exertional near syncope, that patients almost faints due to exertion. It can present as the signs of right-sided heart failure, again due to the hardening of the pulmonary artery that is on the right side. It can also appear as tachypnea due to the shortness of breath. It can appear as a prominent split second heart sound. It can appear as palpable right ventricular heave that can be felt on a physical exam, or it can appear as an elevated jugular venous pressure, which can be seen on the physical exam. Lastly, it can appear as a dependent edema in the lung. Next, so this was the lecture on scleroderma, where we learned not only about what scleroderma is, but its pathogenesis, its manifestations, particularly the skin manifestations and the pulmonary ones. Thank you so much for watching sqadia.com.